When we started working together with iCAIRD, we were focusing on applications of AI to chest X-ray imaging. And when COVID pandemic began in February, March of 2020, we quite quickly realized that we could use our existing resources and technologies to pivot and to start applying AI to applications of COVID detection from chest X-ray imaging. And that really took us into this collaborative piece where we're looking at how we can use AI to help augment the clinical flow, help improve patient outcomes, and potentially lead to early detection of COVID from various imaging modalities.
So iCAIRD is Industrial Centre for Artificial Intelligence Research and Digital Diagnostics, and that's essentially a collaboration between a number of partners in Scotland, and is really an approach to safe and secure AI training, particularly around radiology and pathology, to be able to deliver essentially solutions that the NHS requires. So the collaboration was initially around chest X-rays, as Ignat says, and really be able to streamline the process of how we report and identify chest X-rays that are abnormal, and how we can support with clinicians that have requested that X-ray, be it in the emergency department context or in an inpatient outpatient context, to be able to more rapidly give them highlighted reports of those that are abnormal, and therefore be able to improve both patient safety and the kind of operational benefits of doing that.
As our lead artificial intelligence imaging radiologist from Glasgow, I'll be one of the end users of the product. We will see the images live, so that I've been brought on board to help with the to improve the workflow of how the images will get to the back station and to involve with the training of the chest X-rays. It needs to make sure that the model is accurate, so they've asked for radiology help in training of the X-rays to make sure that it's labeled correctly. So I'm involved with the training and to make sure the end product works for radiologists.
In terms of when we were starting out, we were at a stage where our AI algorithm could look at a chest X-ray and it could accurately identify about 38 different radiological signs. And I think that was quite already an achievement, because an X-ray is a very basic representation of a super complex three-dimensional anatomy. So the fact that we're able to just look at that 2D image and pick up those 38 radiological signs was very impressive. I think COVID was something that clinically wasn't seen obviously before. It presented with very atypical or sort of unusual signs. So a lot of clinicians were looking at an X-ray and trying to identify patterns of what it means to actually exhibit COVID signs on a chest X-ray. And we realized that the algorithms that we already had in place that have already seen X-rays, they were very good at dealing with that kind of imaging. So because of being good at dealing with X-rays, we actually didn't need as many examples of COVID as we may have needed if we were just starting out from scratch. So it essentially allowed us to look at relatively few images of COVID on a chest X-ray, and then pivot the way that our algorithms work so that they would be a little bit more fine-tuned to identifying COVID and then differentiating COVID from other abnormalities on a chest X-ray, like community-acquired pneumonia, or actually just saying, hey, this is a perfectly normal chest X-ray.
Yes, I think it's important to say that the collaboration we established before Work Package 6, specifically within iCAIRD, was focused on identifying radiological signs and prioritizing abnormal X-rays to be reviewed and reported and surfaced to the clinicians that requested them. Because of the work we've done, both in terms of interpretation of a huge number, 1.1 million chest X-rays within Greater Glasgow and Clyde, and also validating that against publicly available data sets from a range of other countries, it was relatively easy to pivot towards COVID as a response because we had a very clear point of starting to see COVID presentations within Greater Glasgow and Clyde, and indeed within Scotland, that allowed us to be able to identify those x-rays that were abnormal and related to COVID because we started to do PCR testing of those patients. I think over the course of the last year, what's emerged is now we're doing point of care testing with COVID patients presenting into the emergency department, but chest x-rays remain a critical investigation in the examination and investigation of anybody with shortness of breath attending the emergency department. That's about 10% of our workload. And being able to differentiate, especially as prevalence of COVID drops, and to be able to support clinicians identifying which is a potential COVID presentation is critical to both safety and, as we move forward, to be able to identify those that require additional screening, additional testing, and potentially cohorting, because obviously admitting a patient with COVID into a general ward can increase the risk of spread. So chest x-rays remain a mainstay of our ability to filter and create a greater understanding of the differential of who's got COVID versus bacterial pneumonia. And AI embedded successfully is a critical step in that clinical decision support for both safety and operational care delivery.
The key thing is that chest x-rays are a frontline test with the results available in seconds or minutes compared to the potential hours or longer for even point of care COVID testing. I think the thing that the x-ray does that the blood test doesn't do as well is potentially grade severity. So we're able to get a frontline handle on where the patient should go or where the patient may be heading in the future down the line. Artificial intelligence, which should hopefully be able to aid grading that severity, which will again hopefully improve patient outcome and allocate the patient the right resources at the right time.
I think that's a critical point, that actually it's not just about identification, it's also about prognostication. I mean, what care they're going to require, is it intensive care, and be able to plan for those, especially when those resources were more challenging to be able to be available. That approach is really important because CT is what's been reported in some other countries, and especially in China, as their frontline investigation. That's clearly not something that we can maintain, and therefore chest x-ray as a kind of primary tool for investigation becomes actually the one we can embed within the clinical pathway moving forward. And I think that ensemble approach of being able to take structured data, so the vital signs like heart rate, blood pressure, combine that with the electronic health record, the data we've already got about that patient, as well as chest x-rays, both allows us to screen, so identify people with COVID, but also phenotype them to both support research around about what drug treatments are appropriate and what escalation strategies are required, but also understand the resource demands in terms of length of stay and the risk of readmission.
Those deep learning algorithms, I think their strength, of course, is that they work very well on what's called unstructured data. So data that doesn't necessarily sit in tables, and it's quite difficult for a human to review and extract meaning rapidly. So those things like imaging and text reports, radiological reports, they're examples of this unstructured data. So deep neural nets, they're very, very good at dealing with that kind of information. The downside of this is that you need a lot of examples of that kind of data to actually train these algorithms. And the more data you tend to provide to these algorithms, the better they deal with this concept of generalization. So how well will an algorithm perform if it's been trained in one hospital and actually deployed somewhere else? And the more data you feed into that algorithm, the more likely it is that the generalization exercise is going to go well. So I think the DGX technology was quite crucial for us as a small business, because it essentially allowed us to take, I would say, what would have been about 18 months worth of experiments and essentially compress it down to about 3-4 months. And I think the fact that we're dealing with x-rays, we're dealing with medical domain, meant that we had to reinvent the wheel a little bit, because we're not really classifying cats and dogs, therefore we can't use things that are already available in the public domain to improve our algorithm performance. We had to reinvent certain things to help our algorithms generalize. And I think one of the key things that came out of that work was We have a very bespoke language model that is able to understand the language of medicine and superimpose these gold standard ground truths in a very automated way. And we trained this model on about 200 million bits of medical texts, which is the largest medical corpus assembled for training of an AI. And it certainly would not have been possible without having the DGX technology. And as a consequence of this, we have very good ground truths, which allowed our algorithms to make the most of the data that we had available to us.
I think it's critical to say that without significant amounts of compute, the ability to manage the amount of data required to produce a performant model is well nigh impossible, and that's where the DGX one came in, is to be able to do this and deliver it within a scale of time that is actually valuable to the project, and be able to provide a solution that we potentially are able to integrate into clinical workflow. And the challenge moving forward is always going to be able to respond to those required AI solutions and be able to develop, validate them within a safe and secure environment and deliver them into the NHS. And that's going to increasingly be a response, is how do we do that in an agile way? And I think the work that we've done within this project provides a blueprint for that sort of collaborative working moving forward.
Sorry, Ignat, is it GPU or CPU processing most of your AI work involves?
So it's GPU mostly, and with RAM, I think, being another serious component. I think before we had to do a lot of acrobatics to try and get our in-house GPU infrastructure to play nicely with the large data sets available, and that wouldn't be. It came at a cost of accuracy and just time spent on coding things that were a little bit too bespoke to be useful beyond the project. And the fact that we had essentially unlimited range on RAM and GPU meant that we can simply forego that and just focus on running experiments iteratively until we find combinations that work. Yeah, I think the accuracy is a really fascinating component with COVID. I think there's an element, usually an element of what is a gold standard ground truth. And I think for the most part, positive PCR result is typically considered to be gold standard, but PCR is only about 85% sensitive. So there's some noise there as well. I think we also carried out the study in what's called a prospective way. So essentially we trained the algorithm on data coming in from March till May. And then we validated the algorithm's performance on real patients coming in to presenting with breathlessness, fever, cough between June and September of 2020. So that prospective element means that the AI sees patients as they come in. So there's no cherry picking of cases. We're essentially stress tested the system under real conditions as much as we can in terms of the data and the population that it sees. So in terms of accuracy, we will look at how our model compares with existing algorithms. So 2 existing algorithms, and we show that in our cases we have about 30% boost in performance compared to what's considered to be gold standard. And I think that is really key. And there is, of course, an element of prognostication, which we still would like to address. And also the element of looking at a multi-center trial where we see how well these algorithms generalize. But what we're seeing is that our models generalize very well between the various data sets on which we evaluated them. There is a considerable boost in performance compared to what's already out there. And I think the question that remains to be answered is how actually well do these models improve clinical performance? Are they clinically useful to make that decision at the point of care?
I think that point about performance is critical, that ultimately the model has to perform to be able to support clinicians and to be trusted by them, and that understanding of where the performance and accuracy sits and how we can further iterate and refine that is critical. And as Ignat says, doing this prospectively to to be able to validate that approach is important, and then to be able to validate that and generalize it across multiple different sites, again, speaks to how that product or service could be deployed across the world potentially. And that's a really critical step as we move forward with this particular project. Ultimately, embedding within clinical services and evaluating is critical to demonstrate the return, and that's both in terms of improving patient and clinical outcomes. And it's really one of these vanguard projects of how can we embed clinical decision support, both for the radiologists, but also for the clinicians seeing those patients, to demonstrate the value that adds, both in terms of making sure we're treating people with COVID with the right medications, but equally those that we don't think have COVID, that we're equally treating them with early antibiotics, or in the case of heart failure, making sure they're actually dealing with that appropriately, because ultimately COVID chest x-rays are relatively unspecific to the human untrained or even trained eye. So therefore AI is about supporting clinicians, both radiologists and frontline in the emergency department or respiratory wards, to identify those that potentially have COVID, to initiate testing, cohorting and treatment. So we're still at feasibility stage for the project. So the next stage is for it to be integrated within clinical workflow and to examine that. And there are really two options. One is around about triage support for the radiologists, to be able to surface to them those that are likely to be COVID presentation x-rays, and therefore for them to put that into the report. But equally, we're very much looking at how we can embed that into the frontline requesting piece, so for in the emergency department in a respiratory ward, and support clinicians by just flagging those individuals that potentially have COVID. And one of the challenges of COVID is that while a lot of people come in with the case definition features of continuous cough and fever and loss of taste and smell, there's a huge proportion that are relatively asymptomatic, especially in the elderly population. And while a chest x-ray remains a mainstay of the investigation, it perhaps is not as high up the differential diagnosis for clinicians, and it's really a way of just re-highlighting that actually this x-ray could potentially be COVID, and for people to engage with that particular aspect of the patient's presentation.
From a radiologist point of view, it allows us to direct our resources and time to the abnormal scans rather than the normal ones. So we'll be able to prioritize the patients who have COVID features and provide a specialist report back to the clinicians within a timely manner. So rather than finding at the end of the day that it's been sitting there for several hours, it can be reported as soon as, or quicker when it's acquired, so that the clinicians can be highlighted to them that it is COVID and they can take the precautions needed.
I think the important thing to say is that chest x-rays are the mainstay of investigation for anybody presenting with shortness of breath. At this point, really what we're doing is we're testing everybody that's being admitted into hospital, and that's really a UK standard of care, and that's a PCR test. It goes to the lab. It takes typically 12 to 24 hours to come back, so there's a considerable lag. We are also doing point of care testing, but both of these tests come with a cost. So it's about £50 per test we do for point of care. And as prevalence drops of COVID, hopefully in the coming months, we need to be able to target that resource to be able to do that testing on those that are appropriate, for which chest x-rays will always be the first test we do for those individuals, and then additive pieces around about point of care testing and lab-based PCR confirmation. So I think it's very much that first step is chest x-rays. So therefore it's really important that we are able to add value at that critical step to flag those individuals at risk, to make sure that we do further testing and treatment as is appropriate.
Five, 10 years ago, there was a real concern within the radiology community that artificial intelligence would do this sort of a job, but I think the hype has died away, and what we're left with is diagnostic support tools at present, and that's what it looks like for the immediate future. It looks like a well-coined phrase that radiologists will be replaced with radiologists who use artificial intelligence. I think what we'll be provided with is diagnostic support, so that we can be more confident with our diagnoses, and we'll be able to use more definitive terminology within our reports, hopefully providing better outcomes to clinicians and with the certainty that goes along with it. I think that as artificial intelligence improves, we'll be able to improve and cut our reporting times. So we'll be able to focus our attention to the more difficult and complex tasks that will have a greater impact on patients. So rather than spending a whole day reporting chest x-rays, we'll be able to shorten that down and spend more time reporting complex CTs and MRIs for cancer staging. I think that's where patients are going to see a benefit. There'll be a reduced turnaround for that. And then I think further on the line from that, artificial intelligence will then have an impact on those more complex studies. But at the moment, it looks to be simple chest x-rays and appendicular x-rays. So I think within radiology, we're now getting excited about artificial intelligence, whereas 5 years ago we were worried. And I think that's what we're trying to do within Glasgow, is we're trying to reduce anxiety and fear over artificial intelligence and really bring about a culture change and a transformation of how radiology views artificial intelligence, so that we're all on board and ready to adapt when it comes along, or ready to adopt and adapt when it comes along. And I think that's what we're seeing within Glasgow at the moment. We're getting various consultants involved with different projects so that there is a base level of artificial intelligence knowledge. So we're ready.
I think there's significant demand on radiologists, and that continues to go up as we're starting to try and streamline processes. We're doing more early investigations, both for stroke and general presentations into the emergency department. And really what AI does is it's augmented insight, it's clinical decision support that allows triaging to be able to surface and prioritize reporting. And part of one of the main thrusts of the original iCAIRD work was around the idea that we do approximately 100,000 chest x-rays in Greater Glasgow and Clyde each year. We're the largest health board in Europe, of which about 30% of them are entirely normal. And if AI with confidence can actually strip those out so they don't need to be reported. We're very fortunate in Greater Glasgow and Clyde, we're not doing a huge amount of getting external agencies to report for us, especially around about chest x-rays, but in a lot of health boards, the cost of outsourcing them is around about £5 per x-ray. So clearly if you can take 30,000 x-rays out of the backlog that don't need to be reported, there's both a cost saving in terms of outsourcing, but equally it allows our radiologists to focus on reporting on hyperacute presentations that we need to be reported soon to support clinical decision making. And I think that engagement piece with AI is critical, and it's about, as Mark says, around culture shift and being able to understand how this is actually going to make your job better and improve your ability to deliver care, which is ultimately what we're all about.
Now, I think there's an element of differentiating or setting the limits to what AI can actually do, because I think a clinician will be making thousands of decisions based on a single image. And AI is only good at making just the one decision. So the fact that there is that element of the breadth of applications of AI is huge within radiology. And I think it's virtually impossible for any single one model to actually be applicable across all of those domains. And I think as Mark said, with this changing in attitudes and perceptions of AI within the radiological community, I think I'm personally very excited about the possibility and the potential of radiologists actually building the AI models themselves to help them address the questions that they're interested in. And I think with the new, I guess, more democratized access to building and training these models through various frameworks and tools available, I think it's very much a real possibility. And at the end of the day, I think any model is only as good as the clinical question that it's trying to address. It's hard with, I'm not necessarily certain in terms of where it would fit in with respect to the vaccination program. I can certainly see that COVID pneumonia is going to join a plethora of different atypical pneumonias that clinicians will be able to see. And I think having that as a potential differential diagnosis is always going to be the case. But it's not going to be as prevalent as it is now. So it's not going to be the fact that it's, you know, it's 20 or 30% of all breathlessness presentations to ED as it is now. It's going to the true prevalence and incidence of it is going to decrease, and that in effect that's going to be mandated by the success of the vaccination programs. But as the incidence normalizes and stabilizes, I think the ultimate question is going to be: is this part of the differential diagnosis to be considered for a patient with a dozen different reasons for their breathlessness.
And I think probably another point that's important to make is that we're starting to look at long COVID. There's a number of academic endeavours are increasingly moving into the question of whether or not there's deployable solutions around about prognostication, not in the short term, around about ITU admissions and treatment options, but actually is there going to be long-term sequelae for those individuals? And we're starting to be able to characterise and phenotype those individuals, both within this work, as we start to get more data around about who ultimately suffers from long COVID and the features actually are to do with cardiovascular and respiratory issues. And how do we actually start to train algorithms that are going to predict those individuals and therefore be able to potentially recruit them into different drug trials or therapy options to be able to reduce future risk of developing long COVID symptoms. And I think that's part of the exciting future of this, is be able to take radiological AI interpretation and add it to other biomarkers ultimately to be able to prognosticate and create signals around about future research. And part of what we do in Glasgow is this triple helix approach of industry, academia and the NHS working together. And sometimes it's the industry solutions that we work with actually point to further academic work, and then we recircle back for that to become a solution with partnership in industry. And that's how that triple helix works, to kind of continue to develop solutions that are of benefit.
So we had, it's a very multidisciplinary collaboration. So from very early days of the project, we naturally had SCAN as our hardware partner in this, providing us access to the DGX system and also looking after some of the infrastructure within iCAIRD. And I think it goes without saying that the clinicians on the ground who've been able to contribute their time and effort into the project, it certainly wouldn't be there without their support. We had vast numbers of academics and various university partners looking at how do we actually bring in the more cutting edge models into the workflow and address some of the challenges that arise as part of the COVID infrastructure. And I think the fact that we're part of this iCAIRD consortium, which essentially democratizes access to all of these resources for us as a small business, that's been immensely helpful. I think without without the access and I think the shared vision that iCAIRD group generally has, I think again would not have been possible to make any progress as we've made so far.
The iCAIRD's collaboration had initiated the work that allowed us to build upon that, and the ability to safely and securely mass download and anonymize images to facilitate AI training, work in partnership with Canon Medical Systems and Bering and some of the other partners within iCAIRD is critical to that approach of being able to respond to future challenges and be able to sit down iteratively and say what are the current challenges, what are the current opportunities, where are the current areas of strategic needs, and start to build AI solutions that actually respond to them. And COVID's been a great example of how we've accelerated and responded to those demands and changes to be able to start to bring all those partners together and ultimately bring the resource that's required, which compute is increasingly becoming a rate limiting step to be able to respond to these challenges. So therefore the work from SCAN has been critical in being able to enable us to respond to these challenges.
I remember when back in April of 2020, we had this multi-partner call when we were just considering setting setting things up formally in Glasgow. And Elon was on the call, and I think towards the end he just said, "Look, we've got infrastructure, and we'd love to be able to help you guys deliver the project." And I think like within 3 days, I thought to myself, it'd be stupid not to take up on this offer. So I just pinged Elon directly, and the fact of how quickly he mobilized his team, how quickly the team responded to our needs, the fact that we had about 5 terabytes of data that needed to be transferred around, and just the general hardware support, the link in with NVIDIA and the NVIDIA machine learning team, it just happened so quickly, so fast, and very, very smooth. It felt almost like it was the first time for us working with Scan, but it felt like we've been collaborating for years. It was that efficient. It's a great question. I think it's hard. I mean, I think this project there are a couple of elements here. I think the fact that we've got the mechanism to mobilize very quickly to address a key clinical challenge. I think because we've been able to do it, we've got the know-how of how to do it again, and there will be plenty of further clinical challenges up ahead. And I think, generally speaking, I think as AI evolves, I think that the technologies, the new algorithms that have come out of this, the new relationships that have been built between the various team members, they're going to be critical if we're going to make it a success in terms of actually having AI help clinicians make decisions at the right time for the right patients.
I would agree. I think it's critical about how we establish collaborations together to respond to challenges and bring academic partners, the NHS and clinical teams together with industry to be able to produce solutions around areas of needs. I think the blueprint of this collaboration is about how we take that forward in the learning of how do we respond, how do we create and develop AI solutions rapidly, but equally validate them quickly to demonstrate their performance and where the clinical utility lies. I think having clinicians in the room early makes us understand really the process and how it can fit into a clinical pathway and what the critical rate limiting steps that are present, and how AI can be part of that solution to support clinicians making better decisions. So I think the future is really around about how we embed AI in critical rate limiting steps as the big hitters in terms of demand, be it heart failure, stroke, and then start to think of those smaller niche solutions. Perhaps the value proposition is not as great at the moment, but when there's an established approach to that, the cost of developing those AI solutions, both in terms of clinical time, technical and expertise, as well as the requirement for imaging, is less.
I think COVID in some respects has been a great accelerator for the project and a great accelerator for artificial intelligence kind of within imaging. So I almost see this project as the exemplar project, or sort of the pioneer for what we're going to come across first within radiology. It will hopefully lead the way as radiology transformation into radiology artificial intelligence imaging. So I see the project as being one of the first examples of how we can use artificial intelligence within imaging to improve patient outcomes. So it's really the pioneer of what we'll see and how radiologists will interact with artificial intelligence.